Yes, I was interested to hear that the spread can go into the voice. Could you touch a little bit on that, how that would present, what changes to the voice there would be?
It's a voice dystonia, the dystonic spasm spread to the vocal cord. And usually the patient will have a croaky voice or a little bit of strangled voice like that with some pitch break because I'm contracting my vocal cord.
And also,
and just before you move on, I do want to hear your second question. I just would like to just ask Stan. Stan, you've done some research on quality of life in laryngeal dystonia, haven't you? Can you give us some perspective on how perhaps just not having a voice actually affects patients as well?
So we've done research on spasmodic dysphonia, where the treatment, favoured treatment, is botulinum toxin into the vocal cords to allow them to change. And one of the most interesting and difficult things for patients in this area is that sometimes they haven't had a voice for a long time. They've adapted, so they don't use the telephone. And then you introduce botulinum toxin, and they can talk. But many of them, their identity is tied up in not using the phone. So the difficulty then is adjusting to a different, crudely, type of person. And then the symptoms come back as the botulinum toxin wears off. And then they have to readjust. And then they've got to go back because it's a cycle. So these issues are really quite difficult in terms of your own identity, how you've adapted, because it disrupts adaptation to the symptoms when they change. And we found that in botulinum toxin in the vocal cords when we looked at spasmodic dysphonia. So it was the cycle was hard to deal with because there were all these changes, relative changes, sometimes absolute changes that you had to adapt and change to, making the cycle of treatment the issue. If you think about the contrast, a broken leg, you learn to walk on crutches, you then learn to be a little bit sensitive and build up your muscles, and then you're back to what you were, and that's your permanent state. It's the temporary relief which is quite difficult to deal with.
I've had vocal dystonia for 30 years, and for 20 odd years it wasn't diagnosed. So yes, I couldn't use the telephone. Email was an absolute godsend. I was regarded as a manic emailer because I couldn't communicate in any other way. But when Botox was injected, it was totally as if I was a new person. I couldn't stop talking. I could answer my wife back, which was tremendous. And I actually found that my identity had returned, and it was an absolute miracle. And can I just ask one question about Blepharospasm? What do you think would be a cure for Blepharospasm? Because all I've heard so far is palliatives, treatments and interventions. Very little talk about an absolute cure. There must be.
There is no talk about absolute cure because there is no absolute cure.
Why not?
Because doctors are not God. And we are limited.
But to sound a slightly more positive note to that, I would say that there are huge strides being taken in understanding what's causing it. And Marion put some wonderful slides showing functional brain imaging. No one could have even conceived of doing that. So, we're not saying never, but at the moment that does seem a way off. But we are just trying to work out, grasp with at the moment what is causing the disease. And Christine, yes.
Daniel, just want to ask, is there much collaboration between what happens in Moorfields and other important hospitals in the UK with Europe and the USA, where a huge amount of research is obviously going on in this field? Do you collaborate?
So the question is, are doctors with experience of the condition in the UK collaborating and aware of what's going on internationally? Paul, would you like to field that one? What are your feelings on that?
I've got the privilege of organising a big meeting next year in Glasgow, which is the British Oculoplastics Surgical Society meeting. And I've invited Dan, in fact, to come and give a talk about that. We're very good in Britain at having these societies, but we've also traditionally had a little bit of an ivory tower attitude to approaching disease. But I think things are changing enormously. I think the era of collaboration is very much with us. And in our field, in British oculoplastics, we're a very small community. So the meeting will have about 300 to 400 delegates. And I don't know what Dan thinks, well, I think I know what Dan thinks, but I think a lot of us are very, very keen to collaborate. I think with all this type of work, it's very, very important to know what data you want to collect, whether it's going to mean anything at the end of the day, whether it's logistically possible, and whether it stands up to any scrutiny at the end. So it's very important to have a goal or an ideal in mind, but it's really important to make sure that at the end of it, there's the outcome that you want.
And I think that, of course, you think about collaborating between different countries, but what we do, me as a clinician, is that I do workshop all over the world. I mean, next year I'm going to be in Toronto, in Montreal, in Berlin, and we exchange. And each time I go teaching, I learn. And it's always expert clinician, and we had meeting in Surrey last year at the same time about dystonic dysphagia, and people came from Turkey and from Copenhagen. So we have a lot of clinical and research exchange. We don't have projects together, but we exchange a lot, and that's the most very important thing, to have small meeting, expert meeting. We are 30, and we just speak freely, show our experience, and see what they are doing, and we learn so much.
Okay, we'll take one last question. Just one last question. Lady in the blue shirt.
Yes, it's a question for Paul. Do you know what the success rate is in the operations, the various operations? Do you follow up on the people that have had those operations?
So there are quite a few reports in the literature regarding outcomes of case series. A case series is essentially a series of patients that normally one individual has operated on. It's very, very difficult to predict the success rate with any great evidence base. As we know, Blepharospasm and a lot of dystonias are tied up with a lot of other factors. So what you'd have to do is you'd have to have a group of patients with pretty much exactly the same severity of disease who all get a certain type of intervention by one type of surgeon, and another group with exactly the same stage of their disease who don't get the treatment, and then you need to follow them up. I don't have that data, no one in the world does. And the problem is that surgery is a tiny minority of the large caseload of dystonias. So we're not operating on all our patients. The vast majority of patients get botulinum toxin. I think if you go to all the centres around the UK, we're probably all doing something slightly different, and that's the problem. Even if you just looked at botulinum toxin, are we all using the same agent? What dosages are we using? How are we injecting the toxin? So all these things, what's the interval between injections? And how are you assessing your outcomes? Even assessing outcomes is really fraught with all sorts of difficulty. So you can produce, I could say to you, I've done 20 of these and my patients are delighted. But what it really means, I'm not entirely sure, because I haven't looked at the outcomes in a scientific and evidence-based way that you have to do. And we know there's something called a placebo effect. Surgery is a placebo, can be a placebo like a pill can be. So we know that some people who get an operation feel better after an operation, even though if you measure the outcomes, they may not be any different. So I haven't really answered your question well enough, but that's the state of affairs we're in at the moment. But the problem with surgery for blepharospasm is that I don't think we have huge numbers at the moment. And to do any decent research with outcomes, you need big numbers.
How many do you think are performed annually of the the different
Of
procedures you
myectomies.
described, yes.
Yeah. You see, a lot of those procedures we do anyway for lots of other conditions, things like brow suspensions, lifting the eyelid. These are very commonly performed procedures.
What about
But how many?
the
Sorry?
stripping? The stripping.
The stripping, I would do maybe 2 or 3 a year, so not many at all.
Right. And do you know how many of those are successful?
Most of them are successful. I would say about 70 to 80% are successful.
Right.
But it's quite, for me anyway, it's quite a big step to go for that operation. It's a big operation with side effects, and I need to be convinced that other treatments haven't worked.
Is this something that's progressed? Because going back 12, 15 years ago, it was very much promoted to have the stripping operation.
I think this is a really, really important point. I think maybe we can extend this discussion later during the lunch break, and I'd love to get involved in that chat as well. But I'm just aware of the time pressures that we have at the moment. But we will definitely be picking that up, and it definitely sounds like our first research priority of the day. So I'd like to, first of all, I hope you'll all join me in thanking the expert panel for spending their time to be here.